Hello, my name is Sibel Renaud, and I'm one of the infectious disease faculty at Stanford and at the Palo Alto VA. I'm a past Stanford Infectious Diseases Fellow. I graduated in 2008, and I'm the rotation director for our ID Fellows, the internal medicine residents, and the podiatry residents who rotate on our inpatient ID consult service at our VA. The Palo Alto Veterans Healthcare System is one of the largest VAs in the country. We have 900 inpatient beds and a number of subspecialty wards, including a large psychiatric unit, a spinal cord injury ward, and a traumatic brain injury rehabilitation unit. Our 15-bed ICU is a combined medical and surgical ICU, and we have an intermediate ICU housing both medical and surgical patients. There's also a dedicated long-term care facility and a palliative care ward within our facility. Our surgical services include general surgery, orthopedics, neurosurgery, cardiothoracic surgery, vascular surgery, and a large podiatry service. On the ID consult service at the VA, we see a range of complex medical and surgical cases. As many of you know, the veterans are a unique patient group. Many have incredible history and stories, and they often have fascinating pathology, often in the setting of significant psychiatric disease. The VA is known for having patients with bread and butter diagnoses. That may be true, but in my now more than 10 years working for the VA, I would say that many of our bread and butter diagnoses have an atypical bent. To give you a sampling, I wanted to highlight several cases where we publish case reports that we've seen over the past few years. So for example, we see a lot of Staph aureus bacteremia, often complicated by endocarditis or vertebral osteomyelitis. But a couple of years ago, we cared for a dialysis patient with persistent Staph aureus bacteremia that seeded his gallbladder as his undrained source. Prosthetic joint infection is also a relatively common diagnosis for us. Last month, we diagnosed a culture-negative PJI as disseminated Coxiella in a veteran with rheumatoid arthritis, tying together as past puzzling hospital admissions for culture-negative pericarditis and culture-negative vertebral osteomyelitis. And another one of our PJI patients developed acute renal failure due to absorption of gentamicin from an antibiotic-impregnated spacer. Lastly, in addition to cases of viral and bacterial meningoencephalitis, we see a fair amount of coccidiomycosis, including coccimeningitis. The most challenging case of coccimeningitis we've seen recently has been in a veteran who presented with CNS vasculitis due to cocci, which was complicated by stroke, and his disease was refractory to conventional medical therapy. For a year, he required intermittent intrathecal ampho and immunosuppressants to control his inflammatory response and to finally control his symptoms. Something I love about working at the VA is that the size of the hospital allows us to have close contact with the inpatient teams. Where on rounds, we're able to visit the team rooms to explain the basis of our diagnostic and treatment recommendations in person. We also have easy on-site access to our microbiology lab, our pathology department, and to radiology, where we're able to incorporate case review with our colleagues in these departments into our daily rounds. On the outpatient side, the VA has weekly fellow continuity clinics both for general ID and for HIV, and both of these clinics are under the leadership of Dr. Arthi Chari, who is also a graduate of our ID fellowship program. Dr. Chari, myself, and our pharmacy leads, Dr. Trisha Nakasone and Catherine Yang, comprise our antimicrobial stewardship program, where we have a collaborative and parallel program to the ASP program at Stanford. In our group, we have monthly meetings with representatives from our microbiology lab, infection control, and our ASP champions from the hospitalist group, the surgical subspecialties, nursing, the MSICU, and the residency program. And by doing this, we ensure that whenever we make new policy decisions or order sets, that we're incorporating input from all of the VA providers. We also incorporate scholarship into our ASP program. Two of our current projects are studying the cost-benefit of following procalcitonin trend to de-escalate antimicrobial use in critically ill patients presenting with sepsis, and also looking at the prevalence of catheter-associated urinary tract infections in patients who have had traumatic urinary catheter placement. The last point that I wanted to make is that while on the VA service, Our fellows have the opportunity to take a leading role in teaching our residents. At the VA, we have a case-based curriculum that the attending and fellow review with every resident on service during their 2-week block. And this allows the fellows to develop confidence while teaching the evidence behind ID recommendations for common ID scenarios seen in the general medicine clinics or on the wards. The VA is a tremendous asset to Stanford Infectious Disease Training Program. Thank you for considering us.